It's been alright, same old, Ain't nothing really different than, from before. Just rough bad days, I guess you say. It's been alright.
What are all your passions in life?
Honestly, I want to go back to school and be a social worker. Because what I went through when I was a kid, what I've been put through, I feel like I can help. I know I can help other kids and even young.
Tonight, in Philadelphia, the historic city of brotherly love, the ideals written into its stones are being tested in the harshest way. Just a short walk from Independence Hall, where the promise of life, liberty, and the pursuit of happiness was first declared, you can stand beneath an overpass and see a completely different story. The echo of traffic overhead, the hiss of buses in the distance, and under the concrete ribs of the city, people trying to sleep on thin blankets spread over cold ground. Here, cardboard becomes a mattress. A backpack becomes a pillow. A plastic bag becomes a nightstand. In these spaces, under train tracks, along industrial corridors, in the corners of Kensington and other neighborhoods, a quiet emergency is unfolding every single day. It is not hidden. It is visible to anyone willing to look long enough to truly see. Philadelphia has always carried a special name, the city of brotherly love. A name built from two Greek words, philos, meaning love, and adelphos, meaning brother. A city that was supposed to stand as proof that people could build a society based on care, mutual respect, and shared responsibility. But on these sidewalks, under these bridges, that promise seems very far away. Here, you see the outcome of three powerful forces colliding at once. Chronic homelessness, where people have gone years without a stable place to live. Untreated mental illness and deep psychological trauma, carried silently in the body and mind. Highly dangerous synthetic substances that offer quick relief from that pain, but pull people deeper into crisis. This film is not about judging the people caught in that intersection. It is about asking a harder question. How did a city built on the idea of love for one another reach a point where so many people are left to suffer in such visible, concentrated distress? Walk through certain blocks and you can see the pattern. Some people stand in small groups, staring at nothing in particular. Some sit against a wall, shoulders rounded, eyes half closed from exhaustion. Some try to organize their belongings into a neat pile, knowing that at any moment they might be told to move on. The signs of long-term street life are everywhere. Feet swollen from endless walking, coughs that never fully heal, wounds that should have been treated weeks ago, faces that look 20 years older than the age on a birth certificate. The numbers tell a piece of the story. Philadelphia has an estimated 5,400 people experiencing homelessness. That number may look small compared with some larger cities, but it does not show the whole truth.
Kind of ruined my life. So pretty much I moved to Douglasville, Pennsylvania, which is near Pottstown, Pennsylvania, and just to get away from like the city life, and I couldn't really take it out there. It was too quiet. Didn't have a social life. I worked every day, and it just became depressing.
Not when suffering is so concentrated in specific neighborhoods. Not when blocks and places like Kensington carry a level of visible distress that feels overwhelming even to those who see it every day. This is not just about substances. It is about the absence of basic health infrastructure. For many people living outside, there is no reliable place to use the restroom, no regular access to clean running water, no safe, private spot to bathe, no locked door to provide protection from weather or from harm, no refrigerator for medication, no quiet room for therapy. Without these basics, manageable illnesses become serious. Treatable conditions turn into emergencies. A simple infection, left unattended, becomes a crisis. Uncontrolled diabetes spirals into repeated hospital visits. A chest cold develops into something life-threatening. When that happens, the city does not save money by ignoring the problem. It pays more. Ambulance rides, emergency room care, short hospital stays. Over and over, for the same people because nothing about their lives has been stabilized. The cost of a single night in a hospital bed or a psychiatric stabilization unit is often higher than the cost of an entire month of rent in a supportive housing program. Yet our systems are still built to pay for emergency responses instead of long-term solutions. The result is a scar, not only on Kensington, not only on Philadelphia, but on the idea that a modern city can claim moral leadership while allowing avoidable suffering to continue in plain view. This film will follow that scar closely. We will trace the arithmetic behind neglect and crisis management. We will examine the policies that turn survival into a legal problem. We will explore the evidence that housing first and supportive care are cheaper and more humane than punishment. And we will end with a choice that belongs to all of us. Will Philadelphia, the city of brotherly love, continue to fund crisis and call it normal? Or will it choose a path that finally matches its name? To understand this crisis, we have to follow the numbers, not just the emotions. Because beneath every tent and under every overpass, there's a balance sheet. Most of us never see it, but the city's budget does. Imagine one person who has been unhoused for years, living with untreated mental illness, and using substances to manage emotional and physical pain. We will not use their real name. We will simply call them the neighbor, because that is what they are, not a stranger from another world, but another resident of the same city. The neighbor spends nights in an encampment near an industrial area. In the winter, the cold cuts through thin layers of clothing. In the summer, the heat off the pavement makes sleep almost impossible. They have no place to store medication, no place to charge a phone consistently, no place to truly rest. When their health worsens, they do not have a regular doctor to call. Instead, their body waits until it cannot wait any longer. At that point, someone dials emergency services. An ambulance arrives. The ride alone can cost hundreds or even thousands of dollars on the system's books. The neighbor arrives at the emergency room. Here, staff do their best with limited time. They stabilize the immediate crisis. They may provide a short course of medication, but they cannot fix the neighbor's lack of housing. They cannot transform a crowded waiting room into a long-term care plan. So after a brief stay, the neighbor is released back to the same sidewalk, the same stress, the same trauma, the same lack of resources. Within weeks or even days, another crisis comes. Another ambulance ride. Another emergency room visit. This pattern repeats. Studies from cities across the country show that a person living outside, dealing with serious health issues, is likely to use emergency medical services 5 to 10 times more often than a housed person. Each visit carries a price. The ambulance, the medical staff, the lab tests, the medications, the overnight stays. Add to that the cost of law enforcement. When survival takes place in public view, it becomes visible not only to concerned neighbors, but to officers whose job it is to respond to complaints. Someone calls about people sleeping in the park. Another call comes in about a person hanging around a storefront. Someone else complains about an encampment blocking a sidewalk. Officers respond. Sometimes they issue warnings. Sometimes they write citations for trespassing, camping, or other public order offenses. Sometimes an arrest is made. Booking one person into jail requires officer time, transportation, intake staff, fingerprints and photographs, medical screening, food and basic supplies for the duration of the stay. Even a short stay can cost $100 to $300 a day. If that neighbor cycles in and out of jail multiple times in a year, the jail bill alone can easily reach $10,000 to $15,000. And we still have not counted the court side of the equation. Each citation and each arrest must be processed. A case number is created. A public defender may be assigned. A judge must review it. Clerks file paperwork. Even when charges are dismissed, time and money have been spent. All of this is happening while the neighbor remains unhoused and unwell. No stable home, no continuous treatment, no chance to reset and heal. When researchers step back and look at the full picture, ambulance rides, emergency rooms, inpatient stays, jail time, hearings, staffing, a pattern appears. The annual cost of managing one person in this crisis loop often falls between $35,000 and $55,000. Now, compare that with the cost of a supportive housing program, often around $15,000 to $20,000 per year, including rent and voluntary services. For less than half the money, the city could provide a safe, private place to sleep, a door that locks, access to a case manager, regular contact with health professionals, support for mental health and substance use treatment. Yet the system continues to invest the larger sum into crisis rather than the smaller sum into stability. From a purely economic standpoint, it is a poor decision. From a human standpoint, it is devastating. This is the arithmetic of cruelty. We pay more to maintain visible suffering than it would cost to significantly reduce it. If the numbers are so clear, why does the crisis persist? To answer that, we have to look at how policies and procedures turn survival into a legal maze. When a person's life takes place entirely in public, almost every basic need can be interpreted as a violation. Sleeping becomes camping. Resting under an awning becomes trespassing. Gathering belongings near a storefront becomes obstruction. Each time, there is the possibility of enforcement. An officer might start with a warning, but if complaints continue, citations follow. The neighbor who has nowhere else to sleep now holds a piece of paper that demands a court appearance. Think of what it takes to successfully navigate that process. You need to know the date and time. You need to keep track of the paperwork. You need to arrange transportation. You need to show up exactly when your case is called. For someone juggling the daily emergencies of street life, who might not have a phone, who might not have a secure place to store documents, this is not simple. If they miss the date, if they never see the notice, or if the paper is lost during a sweep of the encampment, the citation does not disappear. It usually becomes a warrant for failure to appear. Now, every future interaction with law enforcement carries a new risk. A routine check can bring that warrant to the surface. An arrest follows. Back to jail, back through intake, back into a system that cannot fix the underlying problem. When they're released, they may find that their tent is gone, their belongings discarded, their identification lost. Without identification, applying for a job becomes almost impossible. Signing up for benefits is extremely difficult. Even entering some shelters or programs can require an ID card. So the neighbor now faces an even steeper climb than before. On top of that, many housing and employment applications ask about criminal history. An arrest for a public order offense, sleeping in the wrong place, resting too long in a doorway, can still appear on a background check. Some landlords will not rent to anyone with such a record. Some employers will not hire them. The very actions used to manage homelessness become the same actions that make it harder to ever leave homelessness behind. Then there is the sobriety wall. In many cities and in many programs, the condition for entry into shelter or transitional housing is simple and strict. No current substance use. For someone living outside, using a powerful synthetic drug to manage trauma and withdrawal, this is an almost impossible barrier. Withdrawal without medical support can mean severe physical discomfort, high anxiety and agitation, intense cravings, serious health complications. Trying to endure that on a sidewalk or in an encampment, without a bed, without privacy, and without continuous care is more than most bodies and minds can handle. Yet the rule remains. Get sober first, then we will help. From a medical perspective, this is backwards. For many people, sobriety requires stability. A safe bed, regular meals, access to medication-assisted treatment and mental health care. Without those, asking for immediate sobriety is like asking someone to run a marathon on a broken leg. The result is predictable. People who most need help are often the least able to meet the conditions required to receive it. They remain outside. They remain sick. They remain visible. Meanwhile, the city continues to spend money on sweeps, on citations, on jail beds, and on repeated emergency room visits. The intervention has become a loop. not from crisis to recovery, but from crisis to paperwork to crisis again. This is the legal and administrative deadlock that holds the scar in place. If punishment does not work, and if it costs more, what does work? Across the country, one model has shown consistent results in study after study. It is called housing first. Housing first does not mean housing only. It does not mean ignoring mental health or substance use. It means recognizing that without a stable home, it is extremely difficult to address any of those issues. At its core, housing first rests on two simple principles. First, provide housing without preconditions. No requirement to already be sober. No requirement to already be employed. No demand that the person first prove they are ready by surviving more time outside. Instead, the goal is to move people into permanent, safe, private housing as quickly as possible. Second, bring services to the person where they live. Once housed, individuals are offered, not forced, but offered voluntary, ongoing support. Mental health counseling, medication-assisted treatment for substance use, primary medical care, help with daily living skills, support in applying for work, education, or benefits. Because the person has a stable address and a predictable environment, keeping appointments, taking medication, and engaging with care becomes far more realistic. Let us imagine a neighbor named Chris. Chris has been living under an overpass for several years. They have a history of trauma, and they use substances to manage flashbacks and anxiety. Under a Housing First program, an outreach worker meets Chris at the encampment. Not for one conversation, but for many. Trust is built over time. At some point, when the moment is right, the worker asks, "Would you like your own place? We can help with that." When Chris says yes, the focus shifts to action. An apartment is located perhaps in a building dedicated to supportive housing. Paperwork is handled with the help of the outreach team. On moving day, staff are there to assist. For the first time in a long time, Chris turns a key in a lock that is theirs. Inside, there is a bed, a bathroom, a small kitchen area, a place to sit that is not a curb. In that moment, the constant alertness of street life can begin to ease. The next day, a case manager visits. They talk about health. They talk about mental well-being. They talk about the substance use that has been both a coping strategy and a risk. Together, they make a plan. Maybe it starts with a medical checkup. Maybe it starts with applying for a benefit that was never accessed before. Maybe it starts with medication-assisted treatment to help reduce cravings and stabilize withdrawal. Whatever the path, it happens from a place of safety. If Chris has a difficult day, they can close the door and rest. If a therapy session is hard, they can come home to a space that feels familiar. Over time, something else changes. The city stops seeing Chris in the emergency room every few weeks. Police stop encountering Chris during encampment sweeps. The jail system stops processing Chris for minor public order offenses. Instead, Chris appears in a different part of the ledger, as a tenant whose rent is partly subsidized, as a patient seen at a clinic instead of an emergency department, as a person whose support is predictable, not crisis-driven. When researchers track these outcomes, the numbers are striking. Emergency room visits drop sharply. Contact with law enforcement decreases. Incarceration rates fall. In one widely cited example, a program serving people with severe alcohol dependence found that housing and support saved the city more than $2,000 per person per month, compared with leaving them on the street. That is not an outlier. Similar results have been seen in multiple locations. Housing First is not gambling on an untested idea. It is acting on clear evidence. It says, people stabilize better when they are safe. Treatment works better when people are housed. Public money goes further when it buys security instead of repeated emergencies. And beyond the numbers, there is the ethical shift. Housing First begins with a simple belief that a person's value does not depend on their current condition, that everyone deserves a place to rest, to heal, and to hope. It is, in a very real way, a policy model that looks a lot more like brotherly love. Knowing what works is one thing. Building it at scale is another. To move from crisis management to real solutions, cities like Philadelphia need a clear blueprint, a practical roadmap that touches budgets, laws, and daily practice. First, redirect the crisis budget. Every dollar spent on repeated emergency responses is a dollar that is not available for permanent solutions. Cities can begin by carefully tracking how much is spent each year on encampment sweeps, low-level citations, and court processing, short-term jail stays linked to homelessness, emergency room visits, and ambulance rides for preventable crises. Once that total is visible, a portion of it can be intentionally shifted toward permanent supportive housing construction and operations, rental subsidies tied to housing first programs, staffing for mobile crisis units, and peer outreach teams. The goal is not to increase spending without limit. It is to use existing spending more wisely. Second, change who responds to distress. Not every call about someone in visible crisis needs an armed law enforcement response. Mobile crisis units, made up of clinicians, peers with lived experience, and medical staff, can respond to many nonviolent situations more effectively and at lower cost. These teams can offer on-site de-escalation and emotional support, provide basic medical assessment and care, connect people immediately to shelter, clinics, or stabilization units. By reducing the number of situations that default to police and jail, the city can lower both human harm and fiscal cost. Third, invest deeply in peer support. People who have walked through homelessness and addiction and come out the other side carry a kind of authority that no textbook can grant. When they say, "I know what this feels like," it is not a slogan. It is truth. Peer workers can build trust with people who are wary of institutions, help interpret complex systems in everyday language, accompany individuals to appointments, reducing the chance of missed care, model the possibility of change in a way that feels real. Funding peer outreach is not just kind, it is effective. Fourth, decriminalize survival. Repealing or revising ordinances that treat basic human needs, sleep, rest, the simple act of existing in public when there's nowhere else to go, as crimes is a crucial step. This does not mean ignoring community concerns. It means addressing them through services, sanitation, and housing instead of through fines and jail. When survival is not a crime, the cycle of warrants, arrests, and lost documentation begins to fade. Fifth, clear the administrative path. Many people are kept out of progress by simple barriers, missing identification documents, old unpaid fines for minor infractions, complex forms that are hard to fill out without guidance. Cities can support legal aid and nonprofit teams whose entire mission is to help people replace lost IDs, navigate benefit applications, resolve or forgive minor warrants and tickets tied to survival rather than to harm. Breaking the administrative knot allows people to step into housing and work when opportunities appear. Sixth, scale up permanent supportive housing. All of these reforms require one key ingredient: actual homes. That means setting ambitious targets for how many supportive units are needed, streamlining zoning and permitting for projects that meet those needs, partnering with nonprofit and mission-driven developers, protecting supportive housing from unnecessary delays driven by fear or misunderstanding. When the units exist, the transition from encampment to apartment can happen in months instead of years. The scar on brotherly love is not inevitable. It is the outcome of specific choices. New choices are possible. In the end, this is not only a story about Kensington or about one bridge or one block. It is a story about what a city chooses to see and what it chooses to ignore. Under the overpasses and along the alleys of Philadelphia, the city of brotherly love faces a quiet test every day. Will it continue to pour money into a system that moves people from sidewalk to cell to hospital bed and back again without changing their circumstances? Or will it take the same courage that once signed a Declaration of Independence and apply it to a new kind of freedom? Freedom from the impossible loop of homelessness, untreated illness and endless crisis, the numbers are not really the mystery anymore. We know that. Keeping one person in a cycle of street life, emergency care, and jail can cost tens of thousands of dollars each year. Providing that same person with housing and voluntary support usually costs much less. We know that. Punishment does not heal trauma. Tickets do not treat depression. A night in jail does not prevent the next medical emergency. We also know that a door that locks can calm a nervous system. A consistent address can reopen doors to benefits, work, and family. A respectful conversation can begin where an arrest would have ended. The question that remains is moral, not technical. Do we accept that visible suffering in the streets is simply the cost of doing business in a modern city? Or do we say, clearly and firmly, no, not here, not in a city that carries the name of brotherly love. Change will not arrive in a single policy or a single program. It will come from a series of decisions. To redirect crisis money into homes, to replace punishment with care, to listen to people who have lived this reality and include them in designing solutions. Every person under an overpass tonight is part of Philadelphia's story. They are not a separate category of human being. They are neighbors who are wounded by trauma, by bad luck, by inequity, and by systems that responded too late or not at all. Brotherly love is not a slogan carved in stone. It is a practice. It is a choice. To look at someone in crisis and say, you still belong here. You are still one of us. And we will use our resources not to push you further away, but to bring you back into safety, health, and home. When policy finally reflects that sentence, the scar on brotherly love will begin to fade. Not because we turned away, but because we faced it and chose to heal it.